As we know, our population is rapidly aging. Dementia is an increasingly big problem. Everybody knows someone who's been affected by this condition.
We're not going to be able to cure Alzheimer's disease and related conditions in the very near future. And I think TARCC has been instrumental in bringing a bunch of these new, bright people into the field to kickstart their funding such that they become eligible then for funding at the federal level.
So they're really just getting their feet under them. They take the TARCC money and put it to great use, and then continue to make an application for things at the federal level. Much, much more generous and larger dollar values are awarded.
It can be very difficult for somebody starting their research career to get enough funding to put their first set of ideas together, do some experiments, get some data that will allow them to go to the next level and obtain some sort of research grant.
Bringing along young investigators and people who want to stay in Texas, to me, is like one of the most important things TARCC is doing. I was fortunate to get one of the postdoctoral fellowship training grants and recruited a great early postdoc, and she has become an investigator, gotten her own grants.
It is not beyond the realm of possibility that he or she can turn that initial $300,000 or $400,000 into several million. And we are seeing today in TARCC, in the real world, it is happening.
So if Texas has ways of using the seed money to cleverly coordinate these efforts, I think that it bodes well for the future.
Ladies and gentlemen, please welcome back Dr. Rodrigo Morales.
Right. Welcome to this the second part of this session. So I hope that for the poster presenters, you find your way to your posters. And just to let you know, we will have a little bit shorter session in your agendas. If you want to mark that the last session will not be occurring because Dr. Ma excused herself due to the weather. Was bad in Houston. So we will start now with Dr. Maya Henry from UT Austin.
Good morning. My name's Maya Henry. I'm a speech-language pathologist by training, so probably this is time for something a little bit different. I'm going to be telling you about some of the work that we do here at UT Austin, looking at behavioral interventions to promote communication and quality of life for people who have dementia where communication challenges are the most significant feature. My primary collaborator here at UT is Dr. Stephanie Grasso, who's here today. And so I'll be talking with you, giving you a high-level overview of some of the projects that we are working on. All of this work is funded by the National Institutes of Health, NIDCD, and NIA. So many of you are familiar with Alzheimer's in its most typical presentation where memory is the most significant challenge, but there is growing understanding that there are different dementia phenotypes, of course, and some of our patients present with prominent language impairment or speech impairment, and erosion of their ability to communicate is the most significant challenge that they face. And for a long time, these people were told by their neurologists or even their speech pathologists that there just wasn't much that they could do. Today's your best day. You're going to gradually lose your ability to speak and understand language, but there's really not much that we can do to help you. And so our whole enterprise is built around trying to move the needle on that. Clinical nihilism. So we're investigating a variety of treatment approaches designed to rebuild spoken language, to work on other modalities for communication for patients who are losing their ability to speak, bringing care partners into the picture because, of course, they're critical partners. And it's important for us to think about involving them as well. Because this is a devastating condition where people are losing their ability to communicate communicate and connect with the world, there are significant psychosocial ramifications. So we're thinking about counseling and other psychosocial interventions as well. And because these patients have no time to lose, we're interested in making treatment as efficient and potent as we can. So we're pairing our behavioral treatments with neuromodulatory interventions as well. We have a number of collaborators. So these are multi-site trials, collaborators at as I said, my collaborator here at UT, Dr. Grasso. We have a site at UCSF, collaborators at the University of New Mexico, and Dr. Grasso's work involves partners in Spain as well, where they're investigating interventions for people who are bilingual. So just to talk with you a little bit about some of what we're finding. We've just wrapped up a big multi-site trial looking at treatments for spoken language. So really designed to maximize spoken communication for these patients who have trouble with finding words, with articulating words, with speaking in sentences. This is just a snapshot of some of our data. We've completed this trial with about 120 patients and followed them up through 1 year post-treatment. And what we see is a significant improvement in their ability to produce spoken words and sentences. And you see that significant boost here. And the most exciting thing, I think, is that we see maintenance of gains up to 1 year post-treatment. So clearly, there is a reason to intervene with these patients, and we can foster improved communication. On the qualitative side, patients are telling us that they not only see improvements in communication, but they feel more confident, they have reduced frustration, and we're hearing this from care partners as well. We collect baseline imaging to try to understand neural predictors of response to treatment, and we're finding different brain regions in different clinical subtypes of language-led dementia. And by the way, this is, we're talking about primary progressive aphasias here, but these interventions are also appropriate for people with other language-prominent presentations of dementia, So we're seeing different patterns of brain regions that are predictive of treatment response in different subtypes of primary progressive aphasia, those with semantic and non-fluent subtypes where the pathological underpinnings are typically frontotemporal dementia, and in a logopenic subtype where the pathological underpinnings are typically Alzheimer's disease. And these imaging findings are helping us to inform neurobiologically motivated models of brain stimulation to pair with our speech and language interventions. I should mention that we are delivering almost all of this treatment remotely. So our patients are receiving treatment at home after an initial visit. That goes for our neuromodulatory interventions as well. We train people up on using these devices, and then we send them home, and a study team member will oversee remotely delivered brain stimulation along with speech and language treatment. Because these are complex patients, primary progressive aphasia is heterogeneous but also evolving. So their difficulties at one point in time will evolve, and they will have increasing difficulty with communication. So we're interweaving different treatment approaches, working on spoken language while we're working on other communication modalities. As I mentioned, interweaving things like cognitive behavioral therapy with our speech and language treatment. We're very interested in accessibility of treatment and making our treatments most beneficial for diverse populations. So building out our interventions through co-design with people who are bilingual and come from other cultures and different ethno-racial backgrounds. And Dr. Grasso is really spearheading that work. The fact that we can deliver interventions to people in their home allows us to see them wherever they are. So to circumvent whatever mobility limitations that they have, and also to reach a more diverse sample. Some bigger picture perspectives. As I said, these patients with a language-led dementia have been sort of underrepresented in the treatment literature, and we've lacked evidence to support intervening with them, but we have a growing evidence base now that not only can they respond to speech and language treatment, they can recover their ability to communicate to an extent, but that there are also lasting benefits to communication and quality of life. For progressive aphasia and other language-led dementias. Our imaging research is telling us that relatively spared brain regions, nodes, and networks are supporting response to treatment, and that's informing our adjuvant neuromodulatory interventions that we're starting to pair with speech and language treatment. I don't remember what I was supposed to say, but the big picture, these self-advancing slides are really interesting. It's like you don't have control. But the big picture here is really that this kind of treatment really should be the standard of care for these patients and not the exception. We're still seeing that a lot of people who are referred to us for research have never been referred to speech-language pathology by their neurologist. And so we really need to be seeing these patients. We have a lot to offer them. So thanks for your time.
The next speaker is Mr. Jose Rios from UTRGV.
Excuse me. Okay, good morning, everyone. My name is Jose Rios. I'm a research associate for Dr. Khalid Benamar over at UT Health Rio Grande Valley. And today we'll be discussing Alzheimer's disease and HIV and comorbidity. So without further ado, let's get started. Which one is this? Okay, so a brief introduction. As we all know, with Alzheimer's disease being one of the most common causes of neurodegenerative dementia, being characterized by a progressive impairment of cognitive functions. So some pathophysiological characteristics of Alzheimer's disease, including both extracellular amyloid beta and intracellular neurofibrillary tangles. So some evidence of AD-associated pathology in people living with HIV has been reported. So a couple of cases, starting in the first, and then in the case of a 71-year-old man living with HIV for 14 years, following PET imaging, then demonstrated some marked cortical amyloid beta plaque deposits. And the second case, a 70-year-old woman with HIV encephalitis presented with memory complaints. Following PET imaging as well, detected the abnormal phosphorylation of the tau protein. So here, aging is the primary risk factor for Alzheimer's disease, and 53% of American adults living with HIV are over the age of 50. So as the population ages, the number of individuals who experience Alzheimer's and HIV will also increase. So therefore, the comorbidity of these two clinically unmet is unavoidable. So that then leads us to our main goal for our project. And the main goal here is to determine if HIV accelerates the trajectory of Alzheimer's disease, cognitive decline in old age. Excuse me. Okay, so for experimental design, we are using the chimeric HIV model. So the model consists of, starting on the left-hand side, as you can see, injecting conventional mice with eco-HIV, which uses species-specific cellular receptors to enter mouse cells. So the eco-HIV injection of the mice reproduces aspects of HIV and the disease in human beings. So the eco-HIV model, it maintains HIV tropism, and the pattern of eco-HIV distribution in the body is similar to people living with the disease itself. So the two mouse models that were used in this project, starting with the first, is the human amyloid knock-in mouse model. So this is a recently established Alzheimer's disease mouse model in which 3 amino acids within the amyloid beta region are knocked into the mouse APP sequence to express human amyloid beta. And the second mouse model that we use is the tau transgenic mouse model. So this tau line was generated with the human mutation. So the signs of cognitive impairments and the accumulation of the phosphorylated tau protein are age-dependent in this model. So although we are aware there is no perfect Alzheimer's disease mouse model, we use both of these models to see if these models potentially show if HIV favorably interacts with either amyloidogenesis or tauopathy to accelerate the cognitive the decline trajectory of Alzheimer's disease itself. So the test that was used on the right-hand side, as you can see, it is called the Novel Object Recognition Test. So this test is performed in an open field box, and it is a test that relies on the rodent's natural tendency for exploring novelty. So before any of the testing began, starting on the first image, the mice each that were tested were habituated in the arena for 5 minutes without any objects for the first day. So we used this day to let them get kind of comfortable with the environment, just for accurate data result. So after this 24 hours, after the habituation period, each mice was placed into the same arena and now placed with 2 identical objects and is used as the familiarization session for 10 minutes each. And on the third day, following 24 hours after the familiarization session, each mice was then permitted to explore the same familiar object used in the second day, and now a new novel object on the third day. And like the previous day, this is a 10-minute test for each animal being tested. So the time spent exploring each object was then recorded using a video tracking system, and the experiments were of course done blindly to generate the data that we will discuss in the next couple of slides. Okay, so now on to results, starting with the tau mouse model. And as you can see, the eco-HIV promotes the onset of cognitive decline in the tau mice at 5 weeks post eco-HIV injections. Starting from the left-hand side, the data collected is shown by the total investigation time, which is calculated from the time spent on the novel object divided by the time spent on both the novel and the familiar object, all multiplied by 100. So, and as you can see in the first 2 graphs for the eco-HIV, it has still yet to promote the cognitive decline until on the very right-hand side, until comparing it to the post 5 weeks, when we finally start to see the significant difference in the model. So that's indicating a much less time being spent on the novel object for the tau mice group, comparing it to our control wild type. Okay, so now discussing for results for the amyloid beta knock-in mouse model. And as you can see, the eco-HIV promotes, as in the previous slide, the onset of cognitive decline, but this time at 11 weeks post eco-HIV injections. So for this, starting with graphs A through E, as you can see, the lack of effect on the eco-HIV on this mouse model for cognitive function. So using the same previously discussed test of the novel object recognition, you can see weeks 2 to 10, the first 5 graphs, comparing it to on the bottom right-hand side to graph F, where it shows the eco-HIV finally kicking in to promote the cognitive decline. So unlike the last slide, all of this data is collected, showing the total investigation time period. And as for the amyloid beta mouse model at the 11 weeks, much less time is then indicated for spending on the novel object, comparing it to the control wild type group. Okay, so now in conclusion, with all the data that was gathered during this experiments, this data does provide to be the first evidence for an in vivo functional interaction for both eco-HIV and both of the 2 mouse models that were used during these tests. Okay, very quick, I'd like to thank Dr. Benamar, the wonderful medical students, and everybody for making this possible. And thank you everybody in your attendance for your time. Thank you.
Next, we will have Dr. Hannah Hausman from UT Health San Antonio.
See if there we go. Good morning, everyone. I'm Hannah Hausman. I'm a neuropsychology fellow at UT Health San Antonio, and I'll be presenting on evaluating a 2-step cognitive screening process. See if it'll go forward here. Yes, I'm trying to. Oh. There we go. So dementia is a growing public health concern, as we all know, with the prevalence of Alzheimer's disease expected to nearly double by the year 2060 in the United States. Early detection of cognitive impairment is important for improving patient outcomes, reducing healthcare costs, as well as providing timely interventions such as identifying and treating reversible causes of cognitive impairment, providing education on preserving brain health, as well as allowing family members to engage in future planning at an earlier stage in the process. Primary care settings are well positioned to detect at-risk individuals for cognitive impairment because they may be the first to hear of cognitive concerns, and they also have frequent interactions with patients over time. However, currently, estimated 60% of dementia cases go undetected by their primary care provider. And overall, there's an underutilization of routine cognitive assessments in the primary care setting, as only about 16% of older adults report receiving a cognitive assessment as a part of their health care. There are barriers to engaging in early detection of cognitive impairment. From a provider standpoint, they can report concerns regarding hesitancy in choosing, administering, or interpreting different cognitive tools, which there are many, as well as knowing the appropriate next steps following a positive cognitive screening results with regards to referrals, workup, or their own role in dementia care. There are also significant time constraints as these providers are largely focusing on a wide variety of medical conditions and may choose to focus on more acute concerns within their appointments. From a patient standpoint, they may resist the cognitive screening process due to fear of stigma or lack of understanding of its benefits. And then from a provider standpoint, again, they may not be aware of who is an appropriate candidate to receive a cognitive screener at these visits. Given our growing older adult population, it's not feasible to administer a cognitive screener to every single older adult that comes within the primary care setting. So a solution to this problem would be to propose a practical two-step approach to the screening process. Step one would involve completing a risk assessment to first identify high-risk individuals for cognitive impairment. If they're identified as low risk, they could be monitored and reevaluated the following year. Step two would involve administering the cognitive screening test only to those high-risk individuals. A negative test result on cognitive screener could also lead to that monitoring and reevaluation, while a positive cognitive screening result would trigger the need for further assessment of potential contributing factors to the low score, sleep concerns, mood concerns, or an appropriate referral for a neuropsychological evaluation. For our study, we wanted to evaluate this two-step process to be able to determine its effectiveness. So first, we looked at the effectiveness of a risk assessment tool called the Brief Dementia Screening Inventory, or the BDSI, in identifying high-risk individuals for cognitive impairment. The BDSI has been validated in primary care settings, and it asks specific questions about objective risk factors for cognitive impairment, such as history of diabetes, stroke, or if they need assistance in their ADLs. Then we aim to examine if combining the risk screening measure with performance on common cognitive screeners would improve the classification accuracy of cognitive status as either normal or impaired. In this study, we specifically looked at BDSI combined with the MMSE, a common cognitive screener, as well as the Quick Mild Cognitive Impairment Screener, or the QMCI. Dr. Robin Hilsebeck and her colleagues are currently working towards validating an automated cognitive screening tool to look at this two-step approach that's administered on an iPad and combines a working memory processing speed task as well as gathering speech samples from patients and using machine learning techniques to generate a cognitive performance score in less than 5 minutes, which would then provide instructions to the primary care provider regarding what next steps are appropriate. But for the results that I'm presenting on today, we recruited 153 older adults. 50% of the sample were female, 94% white with about 16 years of education, and 57% of the sample were already established as cognitively normal at baseline. Everyone in the sample completed the BDSI risk screener, as well as the two cognitive screeners, the MMSE and the QMCI. First, examining the effectiveness of the BDSI alone in identifying risk impairment amongst our cognitively normal and cognitively impaired individuals. We see that the BDSI correctly classified about 66% of the sample. It performed better in our cognitively normal individuals, only misidentifying 7% of the cases as false positives, or saying that they were at high risk for impairment. However, it misclassified 70% of those with cognitive impairment, saying that they were at low risk for impairment. Next, we then combined the risk status from BDSI and their performance on the common cognitive screeners. And overall, adding this screening information added limited value to the BDSI alone, which was not surprising given the high false negative rate of BDSI at the baseline or by itself. But when we look at the combined models, we see a slight reduction in the overall classification accuracy, a similar pattern of having low false positives but high false negatives. Comparing the two combined models, the BDSI with the QMCI had a slightly better classification accuracy, higher false positive rate, a lower false negative rate for cognitively impaired cases, though again, still misclassifying 74% of those with impairment. So looking at the big picture, a success of this work is starting to create a foundation for looking at a two-step approach to improve that early detection of cognitive impairment within a primary care setting. Incorporating a risk assessment is a practical approach that can streamline our cognitive screening process by first identifying that subset of high-risk individuals to complete screening measures, which can help us reduce costs as well as be more efficient in our allocation of treatment resources. However, clearly from our analyses, there is a need to improve the sensitivity of those risk assessment measures administered at that first step to make sure we're fully capturing those with cognitive impairment. This could include investigating a combination of risk assessment approaches, refining or adding test items, looking at various cut points, or even analyzing risk as a continuous outcome. Altogether, if we can work to refine this two-step approach, we could transform dementia care by addressing gaps in the early detection of impairment, allowing patients and their families to take action earlier, engage in timely intervention, and hopefully improve the level of support, enhancing their quality of life. Thank you all for listening. I'd like to thank our collaborators, Drs. Roop, Hilsebeck, and Davis, and enjoy the rest of your day. Thank you.
Now we will hear from Dr. Manuel Silva Perez from Baylor College of Medicine.
Good morning, everyone. I'm excited to be here. My name is Manuel Silva Perez, and I'm a postdoc associate at Ginny Chin's lab, Baylor College of Medicine. We study AD through mouse models of AD neuropathology, and my work in particular focuses on the link between AD, sleep, epilepsy, and norepinephrine. Alzheimer's disease, as you all know, has many pathological manifestations such as memory problems, neurodegeneration, sleep disturbances, epileptic activity, attention and arousal problems, anxiety, or inflammation. Norepinephrine is an important neuromodulator that is implicated in many of these same domains. Particularly, it has neuroprotective, anti-epileptic, and anti-inflammatory properties. The overlap between AD hallmarks and norepinephrine's effects led us to wonder whether norepinephrine dysregulation may underlie or be a cause of some of AD's symptoms. And the main source of norepinephrine in the brain is the locus coeruleus, and indeed, there's a loss of cells, as shown here, and quantified here in MCI and AD patients. I'm particularly interested in the interplay between epilepsy and norepinephrine. Epilepsy is much more common in AD patients than in the general population, and interestingly, individuals with AD and epilepsy have faster cognitive decline than individuals with AD but without epilepsy. So we wonder whether, given norepinephrine's anti-epileptic effects, increasing norepinephrine in this context would have therapeutic effects. We hypothesized that increasing norepinephrine in an AD mouse model, we used APP mice, would reduce epileptic activity. And our first approach was pharmacological. We used either of two selective norepinephrine reuptake inhibitors for this disappointment and reboxetine. And what do these two compounds do? So as norepinephrine is released to the extracellular space, it builds up and exerts its effects, and then it is actively taken back into norepinephrine axons due to transporters. What these compounds do is blocking these transporters and causing norepinephrine to accumulate. Thus, they are really effective at increasing available norepinephrine. We then assessed epileptic activity and sleep in mice implanted for EEG recordings. Assessing sleep is important because in AD, most of epileptic activity happens during the non-REM sleep phase, which is also the state of deep sleep where lymphatic clearance of A beta is thought to be enhanced. As you can see in this trace showing 6 hours of EEG recording, in controlled conditions upon saline administration, mice had plenty of epileptic spikes, especially during sleep, shown here in blue and purple, but they had almost nothing during wakefulness, shown in orange. Epileptic spikes are these large downward deflections of the signal and are also indicated with vertical lines above. But upon injecting IP ravoxetin or desipramine, there was a strong acute reduction in spikes, which gradually came back several hours later as the drugs were metabolized. Here is a quantification of this phenomenon over the 12 hours after injection. So for the first block of 4 hours, we saw a strong reduction in spikes that gradually disappeared as the drugs were metabolized. This is a quantification for non-REM sleep in particular, which is, again, where most of epileptic activity happens in AD. So we found that, indeed, norepinephrine has anti-epileptic effects in the context of AD-related epilepsy. But we wanted to confirm that it was indeed due to enhanced norepinephrine and not to non-specific side effects. And we found confirmation using a chemogenetic approach. For that, we expressed excitatory dreads in the locus coeruleus of APP mice, implanted them for to be able to specifically activate norepinephrine neurons. We implanted them for EEG recordings, and then administered either of two very selective agonists to be able to stimulate the locus into releasing more norepinephrine. As you saw in the previous slides, in controlled conditions, upon injection of saline, the mice had plenty of spikes, specifically during sleep. However, on the other hand, upon injecting them with the two specific agonists, we saw a reduction in spikes that gradually went back to baseline. And here again is a quantification of the phenomenon. We saw a strong reduction for 4 to 8 hours, which disappeared as the drugs were metabolized. So these results were really exciting. And we wonder whether chronically enhancing norepinephrine could have disease-modifying effects. To check that, we implanted APP mice with Alced osmotic mini pumps designed to deliver either ravoxetin or saline for control over 28 days. And after these 28 days, we took out the brains and assessed amyloid beta plaques. As you can see in this brain section stained for A beta, in saline-treated APP mice, the typical plaque load developed in hippocampus and cortex. On the other hand, upon treating the mice with ravoxetin for 28 days, we saw reduced plaque load in both areas. This phenomenon is quantified here. We saw a strong reduction at 65 and 71%. That red data points indicate the mice shown in the micrographs. And as A beta is produced in an activity-dependent manner, we think that this may be related to lower hyperactivity due to epileptic activity. So we found that increasing norepinephrine indeed has anti-epileptic effects in the context of AD, and it could have exciting therapeutic potential. We still need to learn much more before bringing this to the clinic. However, a transition could be potentially smooth because there are several FDA-approved norepinephrine reuptake inhibitors. Overall, we found that norepinephrine could become a really compelling way to address AD. And lastly, I would like to thank our lab members for their support and camaraderie, and also thank our funders and TARCC for travel funds and also for the opportunity to present here. Thank you very much.
The next talk is from Dr. Sarah Horn from UT Health, San Antonio.
Good morning. Thank you for having me. I'm a movement disorder specialist at UT Health San Antonio, and today I'm going to be talking about a project that intertwines a clinical trial into the routine care of patients with Lewy body dementia. And this project is supported by the Alzheimer's Association. We'll start the talk with some nomenclature. Lewy body disease is an umbrella term that includes both Parkinson's disease and dementia with Lewy bodies. And Lewy body dementia is an umbrella term that includes both Parkinson's disease, dementia, as well as DLB, or dementia with Lewy bodies. These are all alpha-synucleinopathies, meaning that they're caused by an abnormal buildup of clumps of alpha-synuclein that form Lewy bodies within neurons. And these Lewy bodies propagate from one neuron to the next, causing neurodegeneration. By the time that there are widespread cortical Lewy bodies, patients often have dementia and hallucinations as disease manifestations in the Lewy body disorders. Although the visual hallucinations are very common in Lewy body disorders, affecting 60% of people with Parkinson's and 80% of those who have DLB. They're very commonly well-formed visual hallucinations, such as seeing people or animals in the room that are not actually there. And despite how prevalent this problem is in these disorders, the treatment options are really quite limited because most of the medications we have available to us to treat hallucinations, i.e. antipsychotics, can cause worsening of the motor symptoms of Parkinson's, like tremor, stiffness, slowness, falls. So we're limited to three main options: quetiapine, pimavanserin, and clozapine, that have less dopamine blocking effect. And the two first-line ones are considered quetiapine and pimavanserin because clozapine can come with some serious side effects and is difficult to prescribe. Despite this, we don't have much data to support the use of particularly quetiapine in the treatment of hallucinations in Parkinson's disease and especially DLB. On the left are the studies that have been published for quetiapine in this population. They're all less than 50 participants, and they're mixed, some positive, some negative. For pimavanserin, we have larger and more positive trials, but it's worth noting that this population is very hard to recruit. To randomized 217 in the Harmony trial in 2021. They had to screen almost 800 patients, and only 79 went on to complete the study, highlighting how hard it is to retain patients into clinical trials. If you look at a large Medicare database, about half of people with Parkinson's hallucinations are prescribed an antipsychotic. 2/3 are prescribed quetiapine. The second most common prescription is for pimavanserin, and that is in line with the Movement Disorder Society treatment recommendations for hallucinations and Parkinson's disease. You can see that here in the table on the right. We don't know which one of these two medications is more effective, or if they're equally effective for the treatment of hallucinations in Parkinson's and DLB, however. So my research question is aimed at looking at whether one of these medications does better treat hallucinations and delusions in Lewy body diseases, including those with Parkinson's as well as those with DLB. I did retrospectively look at these medications. Previously, I had a cohort of patients prescribed quetiapine and another cohort of patients prescribed pimavanserin at a single center, and I used a primary outcome measure of time to medication discontinuation as a real-world marker that encompassed not only the effectiveness of the medication, but also safety and tolerability in a real-world clinic population. And I found that the patients who were prescribed quetiapine tended to discontinue the medication more early on. And this may be due to side effects like low blood pressure or sedation. And you can see that the quetiapine cohort is here in the dark line in the figure. If we followed patients long-term, though, they were more likely to stay on their quetiapine. And this might be because it confers some secondary benefits on sleep or mood. So I'm currently prospectively comparing these two medications in a head-to-head clinical trial called the CAMELOT trial. It stands for Comparing Antipsychotic Medications in Lewy Body Disorders Over Time. And the first aim of this study is to determine which of these two medications is associated with a greater improvement in psychosis symptoms whenever it's used in a routine clinical setting in PD or DLB patients. And my second aim is to look and see whether either of these medications better treats associated mood, agitation, or sleep issues that often come with psychosis in Lewy body diseases, and also whether there are more adverse events with one medication or the other. This study is intertwined with routine clinical care. So we call that a pragmatic clinical trial. So when a patient who has Parkinson's disease or DLB comes into the clinic and they're having hallucinations that are bothersome enough to warrant the prescription of an antipsychotic medication, they're randomized then and there in the clinic setting 1-to-1 to either quetiapine or pimavanserin. And then we gather baseline data at that randomization visit and also at a routine clinic visit 6 months later. The main primary outcome measure is the Neuropsychiatric Inventory Questionnaire, and I'm also gathering real-world data about what dosages are used by clinicians, whether patients start and end the study on the randomized medication. I hypothesize that pimavanserin may be better at treating the psychosis, and maybe quetiapine will be better at treating associated mood and sleep disturbances. So far, I have 48 patients enrolled, 2 more since I created the slide. It's a mix of PD and DLB patients. 41% of my cohort is Hispanic. That is reflective of the population that comes to our clinic in San Antonio. And if you compare that to other published clinical trials in Parkinson's disease, less than 1% typically are Hispanic in clinical trials for Parkinson's and DLB. I've also had very good retention in the study. I had 1 patient succumb to metastatic cancer, and 1 patient moved away and withdrew from the study. But other than that, everybody has been retained so far into the study. So in summary, with this pragmatic clinical trial, I'm able to not only compare the effectiveness of the 2 most commonly prescribed medications for hallucinations and Parkinson's, but I can also observe how these medications work in a real-world environment. The pragmatic model has allowed for an increase in the diversity of the participants and has also improved study retention of the participants. I want to thank my team at San Antonio, including my mentor on the project, Dr. Seshadri.
The next speaker is Dr. Karian de Souza from Texas A&M University.
Hi, my name is Karian Souza. I'm an assistant professor from Texas A&M, and I am going to be telling you today about some data that is the basis for a project that actually was awarded a TARCC grant and subsequently a DoD grant for studying the effects of circadian dysregulation and aging and the potential for immune changes to be part of the mechanism for that. So we had previously have shown that circadian dysregulation actually precedes cognitive impairment in middle age. A lot of our colleagues have already discussed how important sleep dysregulation and sleep dysfunction is for initiation of dementia and issues with cognitive impairment. Also, unfortunately, about 20 to 25% of the population in the U.S. Currently works in shift work, and so there's severe implications for potential damage to cognition and acceleration of aging in that population. And this study that was we just published at J Neuroinflammation, actually we were looking at the direct impact of circadian dysregulation on cognition. And the model we use is a controlled circadian dysregulation mouse model, in which we used a wheel running to actually record activity. So on the left you can see the fixed group. The animals, I don't know if I can, oops, just went forward, didn't mean to. The animals are usually in the control group are in the regular light dark cycle, but in our model, we shift the schedules for about 80 days so that every 5 days the animals are either during the day it's light or it's at night. And so they don't really have a chance to entrain to a light dark cycle. And then after those 80 days, about over here, they get back to a normal cycle until about middle age. And the shifted group then stays in a normal LD cycle until middle age at about 13 months, at which we look at their cognition, and we also looked at flow cytometry to look at their changes in inflammatory cells. And what we saw was actually remarkable. We were very surprised to see that animals that had been previously in this circadian dysregulation but put back into a normal schedule showed significant cognitive impairment. So over here in yellow is the animals on the shifted schedule. And here are, in red, are the aged animals, which usually are cognitively impaired when we look at a Barnes maze. And you can see that this difference is remarkably significant. We also were able to use our previously developed cognitive index that uses search strategies in the Barnes maze to identify each individual animal with a cognitive index. And in this measure, we also saw that the shifted animals were significantly impaired in comparison to the animals that did not go through circadian dysregulation. And they were just like the aged animals. And so when we further looked at their immune responses in the spleen, we found that there was an expansion of their B cells, particularly inflammatory type B cells, the CLIP-positive B cells, which tend to be known to activate T cell responses, were elevated in the animals that have gone through circadian dysregulation. And that was also observed in the meninges in the brain. And other markers were also observed. And we were not very, this is not great for individuals like researchers who spend a lot of time working at night and not sleeping very well. We also looked at IBA1 as just some preliminary studies and trying to understand what the immune responses in the brain are. And we found that animals that have gone through the shifted circadian group showed an increase in activation, so there were more cells. And we have more data in our poster if you guys would stop by. So the implications of this is that we really do think, based on our data that was previously published and with this model, that circadian dysregulation actually is probably involved in cognitive impairment in aging and via immune activation. And we are currently looking at other dysfunction in the brain, synaptic dysregulation, and other types of immune changes. And with our TARCC grant, we are looking at a potential therapy where we are going to be antagonizing CLIP, which we saw that was elevated, with a peptide, proprietary peptide called CAP, where we are trying to stop this altered immune inflammatory process and prevent cognitive aging in these animals. So one of the things that would be great with looking with our colleagues is there a potential for translatability, looking at human populations and trying to use circadian dysregulation as a predictor, a measure in your studies, and potentially using CAP as a therapy. So if anybody's interested in talk about that later. And we're also looking for a postdoc, and just want to thank Jocelyn, who is sick and is not here today to present. And my graduate students will be at the posters, my undergraduate students. Thank you.
The next talk is from Ms. Caitlin Fastenau from UT Health San Antonio.
Hi, good morning, everybody. Oh, there are instructions for the clicker, so that's helpful. I'm just going to practice. Okay, awesome. Hi, everybody. Good morning or afternoon almost. My name is Caitlin Fastenau, and I'm a fifth-year PhD candidate in the Hop and Beniak labs at UT Health in San Antonio, working in the Glenn Biggs Institute for Alzheimer's and Neurodegenerative Diseases. And today I'm going to discuss one of my thesis projects titled Sialation Patterns in Human Cerebral Amyloid Angiopathy. So to set the stage, there are many types of post-translational modifications, and one of the most, to set the stage, there are many types of post-translational modifications that impact protein and lipid interactions. Glycosylation or sugar modifications are actually the most common form of post-translational modifications in the brain. Sialation is defined as a subtype of glycosylation, which is the addition of a terminal sialic acid residue that is negatively charged to proteins and lipids. Early studies have noted that aberrant glycosylation patterns are observed in Alzheimer's disease brains. Importantly, there is also increased sialation specifically in AD brains compared to controls. Mechanistically, various well-designed glycoproteomic studies have identified that increases in hyperglycosylation are associated with cell adhesion and immune response pathways. But there is a gap in the field. There is a lack of spatial localization and understanding of where these specific modifications are located relative to cell types and pathological aggregates as observed in Alzheimer's. Therefore, today I will focus on the localization of sialic acid. In our early work, we wanted to first broadly understand the glycosylation landscape in Alzheimer's disease. Therefore, we used various cohorts of postmortem AD brains. Our published findings show significant increase in a form of sialation called N-linked alpha-2,6 sialation, shown here in brown. And we saw significant increases in both the frontal cortex and the hippocampus in AD brains. These residues were significantly increased on microglia near amyloid beta plaques, and this was noticeably absent in regions more distal from amyloid plaques. The significant increase in microglial sialation near amyloid beta plaques was also confirmed in our study where we utilized an amyloid beta mouse model called 5XFAD. In this study, we also confirmed the co-localization of this form of sialic acid with microglia. With these novel and intriguing findings of sialation patterns, we wanted to better understand the relationship with sialation levels with other amyloid pathologies. That leads us to today's study. The purpose of the current study was to understand the spatial localization of sialic acid in the context of cerebral amyloid angiopathy, or CAA, which includes the accumulation of amyloid beta pathology in blood vessels of the brain. Importantly, up to 48% of AD patients have CAA. Understanding glycosylation patterns relative to this pathology is critical. It's particularly critical in an era where we have anti-amyloid therapies that target amyloid species that are both extracellular and intracellular. In this study, we had 30 postmortem cases, 11 of which had AD with CAA, 10 with AD only, and 9 as controls, defined as the lack of amyloid within the frontal cortex. We used histological staining and digital pathology analyses focused on the frontal cortex in both the parenchymal and leptomeningeal arterioles, and we also looked at 2 ROIs, intravascular and perivascular regions. As mentioned, CAA is defined as the deposition of amyloid beta fibrils in the smooth muscle of arterioles and arteries in the cerebral vascular system. We were interested in both the perivascular region that encompasses 75 microns from the vessel wall, which included microglia pathology as well as extracellular amyloid beta pathology. And then importantly, we're interested in the intravascular ROI, which was defined as the walls of arterioles excluding the lumen of the vessel. Importantly, in this study, endothelial cells that line the interior surface of vessels are highly sialated, and this has a biological purpose. Negatively charged PTMs help propel blood through the vessel. But our question was, does CAA pathology potentially drive changes in this vessel sialation to a greater extent than observed in AD only and controls? Intriguingly, we analyzed the intravascular ROIs and we found distinct differences between cases with AD and CAA compared to AD and control cases. Here, noted in red and orange, are more drastic levels of this form of PTM, alpha-2,6-sialic acid, in AD and CAA cases. Specifically, arterioles in the parenchyma and leptomeninges of AD and CAA cases had visibly greater levels of vessel silation, with particular increase in silation of the leptomeningeal vessels. Overall, these are unique findings of silation levels near intravascular A-beta pathology. We did investigate the perivascular region, including microglia and extracellular amyloid beta pathology, but for the sake of time, I've only included intracellular. If you're interested, please come check out my poster. Our neuropathological study provides evidence for increased alpha-2,6-sialation in the arterioles of AD plus CAA cases. But what does this mean? Increased intravascular silation could indicate vessel vulnerability in the context of this intravascular A-beta pathology. And understanding glycosylation patterns, the most common form of PTM in the brain, which is highly understudied in my opinion, is important to potentially provide insight on adverse ARIA events that are observed using these anti-amyloid therapies. I just want to wrap it up and say thank you. Thanks to my lab and all the funding sources. I'm also graduating, so I'd love to connect on LinkedIn and talk about my poster and also check out all of the posters affiliated with my labs. Thanks.
Okay. And our last speaker of this session is Mr. Mohammad Houssini from University of North Texas.
Hello, everyone. My name is Mohammad Houssini. I'm a DO PhD candidate at UNT Health Science Center, and today I'm going to be sharing our work on the association of alcohol use disorder and cognitive impairment and Alzheimer's disease. So a little bit about the team. This is a collaboration between the Genomics Core at UNT Health Science Center at the Institute for Translational Research and the GAPS lab at the Icahn School of Medicine in Mount Sinai with Dr. Geeta Pathak, who is an alumni of our lab. It was very nice to get to work with her on this project. And Dr. Zhou is our biostatistician. Dr. Barber and Dr. Phillips run the Genomics Core. And that's us at the AAIC in 2023. So a little bit of background. Alcohol is a problem. There are 15 million Americans diagnosed with alcohol use disorder. And if you work out the math, that comes out to about 5% or 1 in 20 people. And this number, these are the people that met criteria for diagnosis. So it's probably very underreported and likely more of a problem than we think it is. It's uniformly distributed across the regions. Some of the pathophysiology, so you ingest the alcohol, enters the peripheral system, and immediately starts producing reactive oxygen species and inflammatory cytokines and activating inflammatory pathways. It crosses into the blood-brain barrier where it causes a host of problems for the neurons. It can increase apoptosis, necrosis, and activates additional inflammatory pathways, all of which lead to neurodegeneration. So earlier this month, the Department of Health and Human Services put out an advisory report on the risks between alcohol and cancer. Consuming alcohol has been associated with at least seven types of cancer through 4 different mechanisms. So the first mechanism is an increase in acetaldehyde, which damages DNA. The second one is oxidative stress, which I mentioned earlier. The third is interacting and affecting multiple hormone systems. And the fourth is an increase in carcinogenic absorptions. You can see here clearly the brains of an elderly normal person, a person with Alzheimer's disease, and a person with alcoholism. And the effects are very clear that the neurodegeneration caused by chronic alcohol intake is very bad. So what we did is we took 3 large cohorts, the Alzheimer's Disease Neuroimaging Initiative, TARCC, and the Health and Aging Brain Study with an N of about 19,000 individuals. And we wanted to look into the association between alcohol misuse and cognitive status. The alcohol misuse metrics were determined by each cohort. For ADNI and TARCC, it was part of the medical history. And for HABS-HD, there was the audit scores, the Alcohol Use Disorder Identification Test. So we ran 2 models, one for age, sex, and race, and the other age, sex, race, and education. And we did a meta-analysis to see, we compared, you have the common effect and the random effect. The common effect captures the within group variation, and the random effect incorporates both the within group and the between group. So if you look in both cases, the random effect is significantly increased odds risk compared to the regular cohort for cognitive impairment. And also for Alzheimer's disease, we see the same effect. But the interesting thing is that for Model 2, the odds ratio went down when we incorporated education. So that is something that we're interested in learning more about. So the analysis of 3 major studies continues to support the evidence that alcohol is not good for you. And Model 2 shows how education can be a benefit or offset risk. We're not sure if that's due to increased cognitive reserve or if there are other factors or variables at play. So our future directions are, we plan to incorporate some inflammatory biomarker analysis into this project. And I am also working on ethnicity-specific genetic risk stratification algorithms, which should help us understand how risk is different between the different ethnicities, and also epigenetic risk from lifestyle and exposure are things that will definitely help us understand more as this data is new and just now starting to get analyzed. So the takeaway is that the field needs to really leverage these large-scale studies and the advancing AI and machine learning technology that's coming out every single day. We're excited about the epigenetic data. Like I said, I think it will explain a lot of the environmental risks that we haven't previously looked into. And our goal is to promote healthy aging research and better public education, because if people know that you can modify lifestyle choices that may be significantly impacting your health, they may be more inclined to change their behaviors. And then lastly, I would like to thank my committee members and funding and Dr. Pathak for all of her help. Dr. Pathak is hiring, so if you know somebody who is interested in a postdoc, a PhD, master's, or otherwise bioinformatics, please look up the gapslab.com. Thank you so much.
Well, with this talk, we close this session. I hope you enjoyed it. So we will have a break until 12, where we will have our keynote address. And at 1:30, we will start with the poster session. I encourage you to visit the posters, and for the presenters, be on the lookout for judges, because they will be looking for you and your posters as they will be evaluated and possibly getting an award. So thank you again, and I hope that you enjoy the rest of the day.